here in Uganda. And thank you, Dr. Hosna and the organizing committee for giving me the pleasure to be among my colleagues here to speak about this topic. Dr. Saab already, I think, make my presentation a little bit easier and also tough on the other hand, because his presentation was comprehensive, covering the things in depth. My talk today will be around bone metastasis, mainly breast cancer, and about the role of different modalities, PET-CT, MRI, and bone scan in this detection of bone metastasis. So as an introduction, it's the most frequently diagnosed cancer in women. 1 in 9 women will have breast cancer. Worldwide remains the second most common after cancer lung. United States in 2009, almost 200,000 new cases are diagnosed, with almost 40,000 will die from cancer breast. That's why cancer breast is on the cover of the Time magazine. Interestingly, when I was doing literature research for this talk, in the last 5 years, I found around more than 1,000 articles speaking about the imaging of bone metastasis in breast cancer. This is the search. And this one, more than 1,000 in the last 5 years. And the most interesting point for me was that the first thing, which was published in 2010, was about bone scan. So still bone scan, despite all the things about the PET-CT, comes first even on the research basis. Although the incidence is increased in the past 3 decades, but the mortality has been decreasing, and that's because of the advanced new imaging tools that were able to take the metastasis early stage and lead to proper management for the patients. But when we come to bone, it's the most common site for this metastasis, the first site, and around 26 to 50% of patients, cancer breast patients, they will have bone mets. And they develop at 8% of all patients, reaching to 69% in advanced cases. Those are all the statistical facts from the literature about the prevalence and the importance of bone metastasis in cancer breast. And they definitely affect the patient prognosis and quality of life and the management plans. The imaging studies play a role in identifying the body involvement, guide the biopsy size, and assess the response to therapy. Just a small histopathological or pathophysiological reminder for all of us here. When bone metastases usually start intramedullary, and then if they start purely intramedullary, then they will grow and will start initiating what's called osteolytic metastasis. If they are somewhat close to the cortical part of the bone, then they will initiate the sclerotic part of the metastasis, or what we call sclerotic metastasis. And now, the difference in imaging modalities will play all the time the role about where exactly the site of the metastasis. When we have this dotted line is going with the SPECT and the whole body scan, the MRI will detect the internal lesions, the PET or the metabolic imaging will all the time go to the active things. The types are osteolytic, osteoblastic, and exit or lytic and osteoblastic bone metastasis. And in 50% of the patients, they will have the osteolytic start. So they will start at osteolytic and then they will go afterwards toward osteoblastic. Also, as a reminder, the bone metastasis will occur in the red marrow, and the red marrow is located in these areas here, the proximal, what we call the axial skeleton, the proximal parts of the femur, the long bones, and the skeleton, and the sternum. So skeletal metastasis in the breast occur mainly in the spine and pelvis, and then followed by the head and the skull. Now, the outline of my presentation today, which will take around 25 minutes, will be about the whole body scan. And the whole body scan, we're going to cover the SPECT and the SPECT-CT, and then whole body MRI, and then the PET-CT. We have 2 tracer in bone metastasis, whether the FDG as a metabolic tracer or the fluoride, which is similar to MDB. And then at the end, I will finish my talk up talking about algorithms and cost consciousness. And in these imaging modalities, I'd like to speak about diagnostic accuracy, the response to treatment, and some comparative studies between the different modalities. So to start with our famous bone scan, it's a standard initial test, it's a whole body survey, and most importantly, it's a cost-effective so far. The uptake, as we know, reflects the metabolic activity and also the vascularity, the increased vascularity to the lesion. And we know that osteolytic lesions, that's the beginning, but they are followed by secondary bone formation, and that's why we see them. And that's an example of a patient who is having a normal bone scan. Now, literature-wise, and this was a kind of a meta-analysis or a review published in Scintigraphy in 2009. The reported sensitivity so far is around 78 to 100%. The specificity is 60 to 100%, depending on the patient populations in the different literature reviews. The false negatives are coming from the rapidly growing lytic tumors, avascular lesions, lesions with slow bone turnover, and some area lesions, especially in the spine. And I think this is the challenging point for the bone scan. And the false positives are coming because, as we said, it's a reflection of increased vascularity and increased bone turnover, so that can happen also in trauma, infection, osteophytes, and benign conditions. When we have a bone scan by this criteria, which is randomly widespread lesion, that's a diagnostic bone scan, and there will be no further studies. But if we have a bone scan which is showing a single faint lesion in the spine, that shouldn't be the end of the story. Probably you'll have to go further by doing another study like CT or MRI, and like in this patient here, the CT is showing a osteolytic lesion in the same area. So this is a kind of confirmation for a bone metastasis. Interestingly to know that the rate of bone metastasis is also related to the stage of cancer breast. It's less than 1% in stage 1, around 2.5% in stage 2, but when we come to stage 3 and 4, the numbers jump dramatically to 16% and 40%. Accordingly, the whole body scan is not recommended in the early stages of cancer breast, either stage 1 or 2, and highly indicated in stage 3 and 4. The bone scan in the follow-up. Now we have a patient with cancer breast, and we are treating this patient. Should we do serial bone scans for these patients or not? Well, this study showed that the probability of changing from initial negative bone scan to positive bone scan within 2 years was related to the T-staging. So it's 1% if it's T1, 1.2% if it's T2, T3, but when it becomes N positive, so we are moving now to stage 2, then the percentage of changing from negative to positive is becoming a little bit higher. Now, the large randomized level 1, which is double-blind randomized studies, studies show that the semi-annual and every 6 months whole body scan showed more metastases compared to clinical follow-up. However, other studies showed no difference in survival. So that we are detecting more lesions by doing semi-annual bone scan. However, at the end, there will be no difference in the survival. And the American Society of Clinical Oncology guidelines is saying no whole body scan for post-treatment patients who are asymptomatic. So if we have a patient asymptomatic, there is no need for semi-annual bone scans. Now, when we go for bone scan to follow the treatment of the patient to detect the response, well, the favorable response versus prognosis versus progression is related to the intensity of uptake, or we see new lesions in the follow-up bone scans. Well, if we have a good response to a whole body scan, meaning that there is no decrease in the intensity with no new more lesions, then the survival will be longer compared to short survival with no response. That's the recent article in 2007. However, the concern with whole body scan is similar concerns when we are monitoring therapy. I think the favorite thing is the flare phenomenon because it kills 75% of the patients, the relative lack of specificity, and also the reduced uptake in rapidly progressive disease. When we have a rapidly progressive disease, there is no time for the tumor to have regeneration or to have the chance to have sclerotic lesions around the lesion itself. Moving from the bladder bone scan to the SPECT, 50% of lesions, more lesions can be seen by SPECT images. SPECT improves the diagnostic specificity, especially in focal lesions in the spine, and asymptomatic patients also the SPECT can answer many questions. And here you can see that, as you could the guy mentioned, that the negative predictive value is very important. They found in this literature that suspicious vertebral lesions by bladder bone scan can reach a negative predictive value of 98% if we add SPECT to these images. So that in fact, the diagnostic sensitivity for SPECT compared to whole body scan is quite higher, as you can see in this data here. And this is our patient which we saw in the previous slide. This is the one seen in the dorsal spine here. When you do the SPECT study, it's very focal. So it moves from suspicious lesion or equivocal or indeterminate lesion to a definitive lesion for this patient. Now, adding another paradigm for the SPECT is what's called the SPECT CT. It's very helpful for precise localization. And CT will assist in the diagnosis of benign lesions like degenerative change or osteophyte change, so it will reduce the what we call the false positives, because now we have the CT assistance. And the SPECT, of course, is going to show us the bone changes, as we previously said. Now, the limitation of the bone scan with the little lesions can be minimized by the SPECT CT. Now, in this article by Sonomaya on 45 patients, they mentioned that increased diagnostic confidence using SPECT CT compared with separate bone and CT. When we have a CT study for the patient and another SPECT study, if you do a single study on a SPECT CT, there is definitely an increased diagnostic confidence. Like in this patient here, this is the bone scan for this patient showing an equivocal wall activity in the mid-dorsal spine. The SPECT CT shows that this area is an area where there's a degenerative change, the vertebral end plates with osteophyte formation, so it's going with degenerative changes. Now, this is a very interesting study. I want to make it a little bit explain more and more. This is a nice article by Roma et al. On 112 patients who are having equivocal whole body scan, and then after that they went for SPECT study. So they start by whole body scan, and then they went for SPECT. And they found that 52 lesions had indeterminate finding on the SPECT. So despite that we have done SPECT, still 50 lesions are indeterminate for them. And the CT alone showed that 30 lesions are benign, 15 were metastatic, and only 4 left indeterminate. So accordingly, this is a study taken further. The same study, you will feel that the distribution of these indeterminate lesions are mainly in the spine. Like you see, 20% of the lesions are in the cervical spine, 23% are in the thoracic spine, and 19% are in the lumbar spine. When they did the SPECT CT for those patients, that's the indeterminate lesion by SPECT alone, and this is by SPECT CT. You can see that the cervical spine, out of the 11 lesions, 10 are benign by CT criteria, or by SPECT CT criteria, and only one is malignant. When we come to the thoracic spine and the lumbar spine, the numbers are a little bit different. 7 benign versus 5 malignant, and lumbar spine 7 benign versus 3 malignant. So you see here, that's the SPECT alone. Almost more or less similar focal areas of uptake, seen in the SPECT CT. But now when you go to the CT part of the study, it shows that this is the kind of air with degenerative osteophytic changes, while here it's a destructive osteophytic lesion confirming the presence of metastasis. Now moving to another imaging modality, which I think we'll talk about it at the end of the presentation, is the whole body MRI. Well, whole body MRI for some time is entertaining a very popularity. It is becoming very popular for detection of bone metastases, and they are reviewing the coronal images for the whole body. And recently there are so many protocols about using whole body MRI, especially with the 3 Tesla machines. And there are specific protocols, not every MRI. There should be specific protocols for the whole body MRI because they are using what's called volumetric techniques. And they have 2 kinds of coils, something called built-in coils within the machine itself, and another superficial coils over the patient. And by this technique, they can have what's called a true whole body MRI without transitions in the study. And I'm just giving this example here that those group is showing that the whole body MRI is showing 100% sensitivity and specificity, which of course sometimes is a dream for everybody, but it's just to elaborate how the people were enthusiastic about whole body MRI. And that's how it looks, very nice. Everything is clear, and you will see now. Now, it gives detailed images for the bone and the bone model also. The diagnostic value detects more bone metastasis, so it's more sensitive than the bone scan. When we compare the MRI and the whole body scan, these are the figures which we mentioned previously. The MRI is definitely more sensitive and also definitely more specific, even when we are on the low side. We're not speaking about 100%, but even when we are on the low side, still it's more than the bone scan. And without saying it's ideal for spinal pain for patients who are having spinal symptoms, because it can show also the vertebral compression fraction, spinal cord compression, any soft tissue extension, epidural metastasis, all these things can be seen also by the MRI in addition to the bone lesions. And this is a nice picture. This is the whole body MRI, showing the lesion in the iliac bones here, and also a lesion in the clavicle. This is the one seen also here, and seen by the PET. This is the PET CT for this patient. Now taking more focus on the spine, there are multiple lesions in the lumbar spine and also few in the cervical and dorsal spine seen by the MRI, which are all metastatic. When we come to the PET CT, it's only showing few of them in the lumbar spine, while the rest was not seen in the PET part of the study. Now, this is the whole body MRI. This is not a bone scan. This was called maximum intensity projection diffusion weighted MRI, and it's almost similar to the bone scan. You can see the number of the lesions which are seen by the MRI, definitely much more than the bone scan. It's the same patient. Well, it's a metastatic bone scan patient, no doubt, but you can see the extensive number of lesions seen by the MRI in these patients. So you can see more lesions by MRI than bone scan. And this is a bit somewhat unfair study. It's still level 1, which is double-blind randomized study, comparing the MRI with the whole body scan. I was a little bit surprised about the low sensitivity of the one scan, probably because of the small size of the lesions. In this patient, definitely the MRI is much more than the bone scan. However, when we come to the accuracy of the bone scan, it's not that bad in the study, despite this low sensitivity. It's around 93%. While definitely everything in the MRI in the study was extremely nice. Another group from Turkey were a little bit more modest than those in Germany, showing that the sensitivity of the bone scan is 70% on 40%, and the specificity is around 94%, somewhat also showing some doubts about this very high specificity. So you can see that sometimes in the literature, the choice of the patient is very significant for analyzing the data. And this is a kind of, I call it a group from Germany in the middle. They are showing, like I call it, true data, that the MRI is 92% and 90% sensitivity and specificity, the bone scan is in the 80s, which is, I think, what we are seeing in our current practice. So overall, whole body MRI is more sensitive and more specific than the bone scan. Interestingly, the accuracy of both is related to the lesion location. So when we have lesions in the spine, the bone scan is having a limited sensitivity and specificity. When we have lesions in the spine and the skull, the bone scan is much better than the MRI. For the follow-up after treatment, the MRI can show tumor response in 22% of the patients, when the bone scan was saying that there is progression in these patients. And the MRI detects vertebral metastasis stability or progression in around 75 to 80% of the cases. Now, when we come to the advantage and the limitation of the whole body MRI, the advantage is the whole body capability. There is no ionizing radiation, so it's low radiation. Valuable in the follow-up of patients after detection of body metastasis. However, still also is not used or cannot be used for the initial screening for body metastasis because the limited availability of the new whole body MRI scanners, the lengthy procedure, which this protocol here, this is in the protocol, it's 45 minutes, so if you need to take any further sequence, you will add more 15 minutes, changing the patient from one patient to another patient, you are almost ending up with 1.5 hours in doing a kind of skeletal survey, and also the challenge in the interpretation. That's a very important limitation for the whole body MRI. That's why the whole body MRI didn't take over from the bone scan despite of all the very challenging numbers we have seen. Now, we are almost finished 2/3 of my presentation. Now we'll come to the last third, which is the value or the role of PET and PET-CT in detection of bone metastasis. It's known of having an excellent resolution for both the bone and the soft tissue. And now for skeletal metastasis, we have either FDG or fluoride or FDG fluoride. FDG fluoride is similar to MDD. FDG is the metabolic agent which is most likely to going to detect bone metastasis earlier than the bone scan. Now, FDG is the most common, and I think most of you are aware how this thing is becoming popular now, the FDG. And it's taken up directly with the tumor cells and not in the surrounding normal bone. That's the power of the thing. It's taken directly by the tumor cells, not a secondary thing like in the bone scan. And now, by having the PET-CT, we have the morphology and the function, so we can differentiate somewhat very accurately between the benign and the malignant lesions. Now, for stereotypic lesions, we will have high FDG because the amount of the tumor cells are high compared to the sclerotic bone lesion. When we have sclerotic bone lesions, it's less FDG uptake because the amount of normal bone, because that's now very active bone formation, is more than the tumor cells, so it's a kind of a relative thing. Anyhow, the overall sensitivity for breast bone metastasis is ranging from 56% to 100%. So we are still not very optimistic about the role of FDG in bone metastasis. This is the kind of, the thing is always we are speaking about the specificity because we have a limited specificity by the whole body bone scan. And in these various studies, which are fairly recent studies starting from 2009, 2002, 2008, you can see that the specificity is quite high. The sensitivity sometimes are good, sometimes are moderate, but anyhow we are speaking about a very high specificity tool. And it has to say also with the standard uptake value. When we have sclerotic lesions, we can see that it's less than 1, and that's why we have false negatives by the PET. When we have mixed lesions, I mean sclerotic and stereotypic lesion, then the SUV is around 3.6. Osteolytic metastasis, definitely the SUV will be very high. We can use the standard uptake value not really for the primary lesion, but mainly for the response to treatment. And as mentioned previously, when we have a decrease of 30 to 40%, that can relate to favorable chemotherapy response. It's not complete, but it's a kind of favorable response. If it is more than 55 or 60%, then we are going more with a very good prognosis for those patients. And now, when we see the type of the lesions itself in this study here, comparing sclerotic versus osteolytic bone lesions in the SPECT and the PET, you can see here that sclerotic bone lesions are seen very high by almost 100% by SPECT versus 50% by PET. On the contrary, when we come to osteolytic lesions, 100% for the lytic lesions versus 70% by bone scan. This is only a kind of funny article I found mentioning sensitivity of 6% only, and I was wondering what are kind of osteolytic lesions that are put in the article. So just showing the sensitivity, and also they were very unfair also for the bone scan, giving only 30% sensitivity, and that's what I found in one of the respectable journals. Well, I think the idea of these authors was that you have to use both modalities. If you go like this way, now you're not going to take everything. So they were entertaining using the whole body scan plus the FDG together to have a complementary bone detection of all bone lesions, whether you have sclerotic lesions or you have osteolytic lesions. And this is an example of a patient where the bone scan shows sclerosis, so hot uptake, and in the FDG there is no uptake here, and the CT shows that this is a sclerotic bone lesion. And then now this is almost free bone scan. The same patient did a PET study, and you can see the multiple lesions here. So probably these were early lesions on the osteolytic phase that were not seen with the bone scan. Now, comparative studies between PET and whole body scan, as you will see here, the whole body scan, the PET, and then the PET plus the whole body scan. The results for both here were comparable regarding sensitivity, specificity, and accuracy. They were in the range of 80 to 95%, while when you add both together, then the things are getting very high, about close to 100%, when you add whole body scan plus PET scan. And the false negative in the whole body scan were more in the bone marrow lesions, while the false negative in the PET were mostly in the osteoclastic lesions. Confirming the same thing, and another thing saying the same, confirming the issue of the lytic versus sclerotic lesions in the bone scan and in the PET studies. I think the real role of FDG-PET is in the follow-up after chemotherapy. And it has an excellent tool. As you can see here, the change in the SUV values, the percentage of change is significantly seen with the osteolytic lesions. You can see from 95% up to 20%. And this is another, and when we come to osteolysis, the decrease is not as significant as the osteolytic lesion. So even the response in patients is different according to the time of the initial metastasis. But definitely, you can see the decrease in the uptake is correlated very well to the pre-therapy and the chemotherapy and the post-chemotherapy of those patients. And here, the SUV was the best predictor for differentiation between non-responders to responders. The change in the SUV value was significantly more than the change in the CT attenuation in the follow-up of those 100 patients. And this is a case example of a pre-therapy FDG-PET CT showing a liver metastasis plus also a vertebral metastasis. You can see it here very clearly, a osteolytic lesion and intense uptake. And then post-chemotherapy, the lesion almost disappeared and then converted to sclerotic lesion by the bone scan, by the CT, and this is a favorable response. Another intense lesion in the sacrum, seen here, and then almost complete response with small partial, small residual seen in this lesion. So it's an excellent modality to show the response after chemotherapy. Now, coming to the F18, it's different than the FDG. Now we are speaking about a tracer which has been used 40 years ago. That was the initial tool for diagnosing bone metastasis in the bone scan. I haven't seen it in my practice myself, but nowadays it's coming again with the new machines of the PET-CT. In fact, when I see the data about the F18, it's really fantastic. I mean, the first pass extraction, because it's smaller molecule, is 100% for the F18 compared to 60% for the MDB, so it's really almost double. Then the regional clearance for the F18 from the plasma to the bone is about 3 times higher in metastatic lesions compared to benign bone lesions. So you have what's called target to non-target ratio, very high with the F18. Accordingly, it's giving what's called excellent image quality compared to whole body scan, whole body MRI scan. So it's more sensitive than the whole body scan. Additional lesions definitely can be seen more with the FDG and PET-CT. However, because of this high sensitivity, minimal changes and minimal gene features can give you false positive findings. And in this German group, in the Medical Journal of Radiology 2008, they said that 10% of the patients, the management has been changed because of the use of F18. This is a case example of a whole body MRI scan showing multiple beds, but then you can see this is the F18 for this patient. This is I mean, when you go retrospectively, you will start now saying, well, it's also seen here in the bone scan, and another lesion here in the STL bone. Well, so definitely it shows more lesions like this one here, this one here, and detailed, of course, excellent image resolution by the F18. Now, the whole body bone scan versus the F18 versus the FDG. This is the whole body bone scan, multiple compression lesions. Now, this is the metastatic lesions, widespread, and then the FDG is showing also the widespread metastasis, and they now adding also the other dimension for detecting soft tissue lesions. But this is not only the story. If you do only FDG PET study, like in this patient here with metastasis, with cancer breast, you can see that there are some lesions seen here in the pelvic bones, like this one, and this one here. But if you do F18 PET-CT, the lesions are more clear and definitely showing themselves without doubt. Well, I was trying to look for the comparison between the PET-CT and the whole body MRI, but I didn't find that much studies in the literature about comparison between PET-CT and MRI, because now we know that the MRI is more sensitive and more specific than the PET-CT than the whole body bone scan, and also the PET-CT. So in fact, this group on almost 100 patients showed that the sensitivity for detection of distant metastasis in general, not only bone metastasis, is 93% for whole body MRI versus 94% for PET-CT. When we come to bone metastasis, they showed that 85% for MRI versus 62% for PET-CT. When I'm speaking about the FDG, don't forget that. And in another group, they found that it's also different according to the size of the lesion itself. And they found that the cutoff lesion for the MRI is 2 millimeter lesion, while for the PET-CT, the lesion should be more than 6 millimeter. And then the sensitivity accordingly was 90% for whole body MRI, almost 80% for the PET-CT. When we come to the specificity for the PET-CT was higher than in the MRI. And the false negatives in the PET were related to the lesion size. And also, because you know in the PET-CT we are scanning from the eyebrows to the bedside, so we can miss the lesions which are in the skull or the femur, and those are the things which can cause false negatives or misses. And here, this is the size of the lesion. You can see that this is the golden standard. The PET-CT and the MRI all the time is better when we come to the size of the lesion. Now, this is, I think, to conclude my presentation here, I'm going to speak about the last part of the thing. It's part of my own vision plus also the literature algorithms. Now, we have to be aware that this is the map for the United States, and I was a little bit surprised when I found this dark blue mean that the PET centers are more than 100 in these areas. One is this light blue is around 50 to 75 PET-CT center, and then around 50, and then around 10, and only few states which are having like 0 to 9. So you can see in the United States, the number of PET-CTs is almost 2,000 PET-CT, okay? And now, of course, the literature is full of PET-CT articles now, and definitely they are all coming from this area, and also from Europe area. Now, to be fair, that shouldn't be our case here, because in Egypt, for example, we have, as mentioned today, we have only 5 centers in a 70 million population, while here they have 2,000 PET-CT centers in a 300 million population. In the whole Arab countries, it's few scattered PET-CT. Saudi Arabia having 3 centers, Kuwait are having 1 center, Emirates still they are in the process. I'm not aware how it is in Libya, and Algeria, in the west part of the Arab countries. So in fact, the role of the PET-CT in breast cancer has to be taken somewhat more cautiously. And also the force consciousness thing. Now if we compare, this is a quite old study, not quite old, it's only 5 years ago, but I found that they are comparing very nicely between the prices for, this is the bone scan, it's around $200. When we come to MRI, it's around $500, and PET is around $2,000. So taking those 2 things in consideration, I'm going to show 2 slides. The first slide is when you have no PET-CT center. Like in most of the nuclear medicine studies and most of our countries. So we will start by Scintigraphy, as usual. If it is negative, halas, it's no metastatic disease. End of story. If it is positive and having multiple typical random lesions and multiple atypical lesions, when we have positive studies also metastatic, but if we have negative bone scan with symptoms, and we have multiple atypical lesions or photodeficient lesions, we will add one more step, which is a sheet X-ray, and then the X-ray will tell us either to confirm the benign process, or and then make it no metastatic disease, or showing metastatic disease, and then now we have this thing, and then before starting the treatment for this patient, we might obtain CT or MRI to follow up the treatment for this. This is up to the oncologist. So this is the thing, the most popular screening or for bone metastasis. Now, if we have an X-ray which is showing us negative, but the patient is symptomatic, or suspicious but not typically benign or metastatic, so the X-ray is not able to answer the question clearly, we would go for either CT or MRI. CT for the realized bones like in the red lesions, and MRI for the rest of the lesions. So the MRI can answer the question if it is positive, then we are metastatic. If the lesions are equivocal, then we have to repeat the MRI in 8 weeks. If the lesions are negative by MRI, then we have no metastatic disease. So this is for the centers which have no PET-CT. In lucky centers where we have PET-CT, or patients who are rich that they can pay for the PET-CT, it will be the same diagram. That's the classic way, but we will add only this arm of the PET-CT. When the MRI is not able, instead of repeating the MRI after 8 weeks, we will do PET-CT, or when the MRI itself is not treated, need no whole body scan. It's not appropriate to determine the response to treatment by bone scan, and now immediate, that's the role of the nuclear medicine physicians and residents, that immediate review of the blood whole body scan will tell you if you need SPECT or SPECT-CT without doing a second injection. For the whole body MRI, it's more sensitive and specific than the whole body bone scan, and more or less similar, even sometimes better than the PET-CT for osseous metastasis. The recent MRI techniques can detect osseous metastasis that's not seen by the PET scan or the whole body bone scan, however, limited availability, lengthy procedure, and then the most important, the challenge in interpretation. For the PET-CT, FDG PET-CT is excellent for osteolytic metastasis, however, limitations for sclerotic lesions. F18 PET-CT is similar to MDB, but it's more sensitive on the expense of more false positives. Whole body scan and FDG PET-CT can play a complementary role to increase the accuracy for detection of bone metastasis in general. Now, coming for response to treatment, bone scan is having this advantage of the flare phenomenon, so it's not good. CT is having the diagnostic dilemma because of the morphological change needs significant time to show you the response. MRI is having a good rule, around 75%. PET-CT is having an excellent role in monitoring the response to treatment. And this will be the end of my talk.